Hello and welcome to this webinar. I'm Leo Briggs and I'm going to be talking about reducing the risk of periodontal litigation. Just a little bit about me. I've been a dentist since 1989. I've worked in community, I've worked in general practice. I did a master's degree in perio at Eastman, which I got in '95, and I'm on the specialist list for periodontics. I started working at the DDU 20 years ago, originally part-time, went full-time in 2009, but carried on working in practice until 2017, treating perio patients on referral. In 2016, I became deputy head of the DDU, and that's the role I still do. So what I'm aiming to do today is to provide an update on some of the dental legal difficulties that our members face when caring for patients who have perio disease. And that's the basis of this, so that you can help understand some of the difficulties that can arise and hopefully work around them. Just a little bit about DDU. We are run by our members, for our members. We're led by dental professionals. The team of advisors here consists of dentists and therapists. So we have got therapists, advisors who can advise our DCP members. So just first of all, if you could let me know what your role is. And so if you could just do the poll, it's really helpful to understand who's in the audience in this live webinar. Most people are dentists or hygienists and therapists, which isn't a surprise. So yes, hopefully this webinar will be really directed towards the clinicians who treat patients with perio. Now, just a few things to reassure people about before we get going with some of the specifics about perio. You're not negligent just because something goes wrong. You're only negligent if what you are doing is not supported by what's termed a responsible body of dental opinion. Now, what that means is organizations which provide authoritative guidance. So for example, with treating perio patients, organizations like the British Society of Periodontology would be regarded as a responsible body of opinion. Other examples of responsible bodies of opinion for things like record keeping would be the Office of the Chief Dental Officer, the CG Dent guidance on record keeping, etc. So there are various different responsible bodies of opinion. It also includes what's taught in the universities, but those are the sorts of organizations that we always look to see what guidance there is. And if you are following guidance from an organization like that, you will not be negligent just because something goes wrong. Another thing to be aware of is that there can often be more than one responsible body of opinion. You don't have to be following the majority one. It can be the minority responsible body of opinion. There are often legitimate differences of opinion between clinicians about how things should be treated. A good example of that with perio is the difference as to whether you treat something surgically or non-surgically. There are good responsible bodies of opinion for either approaches, very often depending on the specifics of the circumstance, but it can often be what works best in your hands will be the ultimate decision about which way you think it's best to treat the patient. And so, but it's important that you are always following a responsible body of opinion. That doesn't mean that you blindly follow guidelines. It's important that you are aware of the guidelines. And it's also important to be aware of when a specific patient doesn't quite fit those guidelines or you need to do something else. But always make a note of that when you are deviating from it. And it's also important to remember that nobody sets out to be deliberately negligent. Nobody wakes up, well, I hope nobody wakes up thinking that they want to harm or going to harm a patient. might be one or two patients who you sort of fantasize about wanting to harm, but that's very different to waking up and thinking you are going to go out and harm them. Negligence happens because people lose concentration, which is understandable, but it's dentistry is a high concentration profession. You have to be on the top of your game all the time. You have to be thinking, why am I doing this? Is this the right thing to do? And if you're doing that, you're unlikely or less likely to hit problems. Three other concepts with negligence are duty of care, breach, and causation. And again, just a bit of jargon busting with this. Duty of care means that you owed that patient a duty of care, and that can be established really easily. As soon as you provide any advice to anybody, you owe them a duty of care. So if you are speaking to someone over the phone, if you meet someone socially and you give them some dental advice, you've established that duty of care. So always in those social situations, the advice should be see a clinician, get it looked at, get it sorted, would be a good advice to give. A breach of the duty of care means that you fell below the standard expected of you. And so that would then mean that you were negligent because you haven't reached the standard expected of you. If you're a general dental practitioner, the standard is that of a reasonable general dental practitioner. If you're a therapist, it's the standard of a reasonable therapist. For me, I'm a specialist, so I'm expected when I'm doing perio care to be at a higher standard because of my specialism. And causation means that the patient suffered harm as a result of the negligence of the breach of the duty of care. For patients to be entitled to compensation, they have to have met all three of those things. There has to have been a duty of care, you have to have breached it, and they have to have suffered harm. An example with perio where they might not be able to establish the causation, as we would put it, is that, for example, a patient wasn't diagnosed and wasn't treated with periodontitis, but when they are diagnosed and treated, they never get their hygiene good enough. And so you might be able to say, well, you would have suffered the harm in any event. Nobody likes to do that. Nobody wants to be in that position because you're actually saying, I didn't do what I should have, but sometimes we do have to run those types of arguments with a claim so that the compensation isn't paid. It's harsh when it comes down to it, and looking at these things coldly can be quite upsetting sometimes, but that's the sort of thing that we have to do when we are assisting members with a claim. And looking at these, what's going on now with the picture of with the braces on. Clearly, those braces are doing harm by staying on. They should be removed. I don't think anyone could argue that they should stay on because they are so plaque retentive, and there's a hell of a lot of plaque there anyway. The OPG. Look at that, the numbers of implants there. Why have they been put in? What are they doing? Half of them aren't even supporting anything. They're just there for the sake of being there. So, has the patient suffered harm by having all those implants put in? Potentially, yes. Are they doing any damage? That's hard to say. We'd have to look at it clinically. And then the other one, that nice grill, I guess it is, that's really interesting when you start thinking about things like that. Was it an appropriate thing to do? It might have been in the circumstances. Is it something that's removable? Is it cleansable? What were the teeth like underneath? Have you caused any did the teeth need treatment anyway, and so this is what the patient wanted. But if you were removing healthy tooth tissue to do something like that, the balance becomes more difficult to decide. Also, with something like that, you have to factor in, this is fashion. Will the fashion change, and what will you need to do if the patient no longer wants to wear something like that? So the decisions are more nuanced with treatment like that. From my perspective, from a periodontist, the primary thing I'd be thinking is it cleansable? Can you clean between the teeth? Can the patient easily do that? And that is something that always needs to be thought about. And it's always good to look back at history. Now, look at this. This was from before the time of the Norman invasion of Britain, before 1066. Look at that. Follow the instructions to scrape the teeth with concretions or gritty deposits until nothing of those substances remain. So it's fairly harsh toothpaste, gritty deposits, but look at that. What has actually changed over all that? Well, it's a millennium now, isn't it? What's changed? Clean your teeth to get your gums under control. The fundamentals haven't changed at all over that period of time. So what is a periodontal patient? I think good definitions are patient who requires therapy because of active disease, or someone who requires therapy due to the effects of past periodontal disease. Or rather than treatment, I think care would probably be a better word, because there might be patients who have got their perio under control, they're stable, but then they still need the care to make sure that they're staying stable, and that you are aware if something changes, if that stability is lost. And so that's a really important thing to remember. With periodontitis, or a periodontal patient, you've got to keep on reassessing them. You don't say, right, that's it, you're cured, off. And what are you trying to do? Well, you're trying to produce a maintainable state of periodontal health. So the patient must be assessed, they need to be treated and reassessed. And it's that cycle of assessment, treatment, reassessment is always necessary for someone who is prone or has had or has got periodontitis. So you're actually thinking more like a physician. If you've got something like high blood pressure, your doctor will give you medication often, or lifestyle changes. You'll monitor it, you'll see if it's working. If it's working, great, you'll carry on monitoring it. If it's not working, you might change the dose of the medication, you might try something different. So it's a case of try it, see if it works, and then if it doesn't, try something else. And that's how you need to be thinking when you are treating someone with periodontitis. The trouble with dentistry, or not the trouble with dentistry, but the trouble with the way we've been trained is we think much more surgically. We think, remove it, replace it, job done. And also the way that we're paid tends to work on that model. So that's one of the issues that you need to square when you are treating patients with periodontitis. So, getting the basics right. Firstly, make sure you diagnose the difference between gingivitis and periodontitis. That's essential. And be really careful with auto notes. We see quite often in records that it will say that there's, say, been a BPE of 3 and 4, and then it says diagnosis gingivitis, when clearly it isn't. And it's been an auto note that's been used and not edited. I saw one a few weeks ago where it had the diagnosis as both gingivitis and periodontitis, because the auto note just hadn't been edited and both auto notes were put in, which is such a shame. Because the trouble when you do that is if your records are scrutinized, people will say you clearly got it wrong. Or they say they're just auto notes, how can we trust everything else? So get those basic right. Make sure you diagnose the difference between gingivitis and periodontitis, because it's essential to do that, because the management of the patient will be different. So what causes periodontitis? Well, it's no surprise, it's plaque. Plaque is the primary etiologic agent in the vast majority of conditions. One or two exceptions to the rule, but basically plaque causes periodontitis. Plaque, what is it? Firmly adherent mass of bacteria in a mucopolysaccharide matrix. It's organized as a biofilm. And again, that's a really important concept to understand, to appreciate, because a biofilm means that the bacteria within it behave differently because they're in the biofilm than they would as standalone organisms. So you sort of have to think of the plaque as an entity in itself, rather than thinking about how the constituent parts behave. And that's really important to understand. You can't just think, right, there's that bug in there, that's causing the problem, it does this, it does that, that bug will behave differently because it's in a biofilm. So it's a complex community of microbes with the extracellular matrix and extrinsic polymers. So it has a 3D structure. It is very highly structured as well. It's got protection from drying, protection from the host defenses, protection from antimicrobials because of the structure of the biofilm. And as I said, the bacteria behave differently simply because they are organized in that biofilm. So again, it's really important to understand that concept when treating patients with periodontitis. And it helps explain why some patients can have a small amount of plaque and get a lot of periodontitis. Some patients can have massive amount of plaque, get massive amount of gingivitis, but no periodontitis. The other thing that you need to factor in as well is the secondary factors. And those also have an influence on whether someone is going to get periodontitis or not, and also the rate of progression if they do get it. So plaque causes the vast majority of periodontal diseases. And it is the single most important agent, but the secondary factors can influence the progression of the disease. So what type of secondary factors are there? Well, there are a lot of them: age, gender, stress, genetics, socioeconomic status, oral hygiene, smoking, and systemic disease. Some of these can be interrelated as well. So socioeconomic status, your age might have an effect on your socioeconomic status. Age might have an effect on your oral hygiene. Stress might have an effect on your oral hygiene. Systemic disease might have an effect on stress, etc. So it's a complex web. Again, you can't think of them as standalone entities. You need to think of them how they are working together. And that's an important thing to remember as well. So second poll, which do you think is the most important secondary factor? So if you can start voting, which do you think would be the single most important secondary factor? Right, so I think that's probably about it for the voting. So let's see what people think. Oral hygiene and smoking come out the top from the voting. And yeah, I'd agree with that. Your oral hygiene, because that's affecting the plaque, is important. And again, smoking is one of the most highly researched, one of the secondary factors. And if people smoke, it clearly impacts on the disease. A patient who smokes is more likely to get the disease is more likely to continue. It's more difficult to get it under control, and if you get it under control, it's more likely to return. So smoking does have a big impact. As I've said, the particular influence of each of those factors it is patient specific. So what you can't do with any one of them is say, you've got that secondary factor, it is going to influence it. What you can say is, with that secondary factor, it might influence it, or it's likely to influence it. So it's not a straightforward binary relationship. So again, with getting the basics right, make sure that you record the secondary factors, make sure you know what the patient has, have a good medical history, have a good drug history, understand about patient stress levels, ask those questions about that. It can be helpful to put them in context sometimes, to say, you know, that stress can affect your gums, so I need to know about that type of thing. Just asking that little question can really help put it in context, so that patients don't think you're just being nosy. They know there's a reason why you're asking that. With the smoking as well, patients often get a bit upset. And sometimes the veil comes down when you start talking about smoking cessation. You know, that, yeah, heard it all before. So again, ask the questions in sensitive ways. And one of the things to think about doing is saying to a patient, you know, if you smoke, it can affect the gum disease, explain why, and say to them, if you are interested in quitting, let me know and I can guide you to where you can get extra help. And just gently let them know that you will ask about their smoking each time, so that you understand how it's affecting it. So that way you're not nagging the patient about it, but you're trying to help them, but help them when they want help. As I've said, it's a major risk factor, and we've known about this for a long time. I mean, this was from 2000, and the research had been going on beforehand. I mean, when I was doing my master's degree back in 93 to 95, we were asking patients about their smoking status because the relationship was known about. So it's been known about for a long time. The systemic disease links are becoming more and more established, more and more understood. There's more research being done on them. So the different diseases and how they are interrelated with the inflammation in the mouth, we're gradually starting to learn more about it. But again, causative links aren't necessarily established. It's not that you've got diabetes, so it will cause periodontitis. It's more of a nuanced situation. How can you quantify the influence of the secondary factors? Well, there are various things that people have tried to do. There was a web drawn up by Professor Lang, which a lot of people find really helpful. You can record them in a chart like this. There's different ways of doing it. When I was working clinically, I just used to store up in my head what the different secondary factors were. Obviously, I'd record them, and then I would discuss them with the patient and try and gauge how much of an influence they were having. But there is this website which has got various perio tools which you might find helpful. Again, it's not that any of these things you must use. It's a case of, if it works for you, use it. But be aware of the different ones that are out there, so that you can see, try and pick one that works for you, and use it. Get used to using it, so that you can help assess the influence of the secondary factors. Something else as well, which is really important, is that the diseases aren't curable, they're controllable. And so they must be assessed, they must be monitored. And it's important that you do that consistently, so that you can compare your last set of measurements with your next set of measurements. So what can be assessed? Well, there's loads of things. You can assess plaque, gingival inflammation, calculus, periodontal pockets, recession. All of these things can be assessed. You don't necessarily need to assess them in every patient, but there are some patients where you will need to assess all of these things because all of these things will be affecting them. They're likely to be wanting to refer them on to a specialist if they have got all of those things, but you need to assess that so that you can make an appropriate referral. And there's no one simple way of assessing if a site is stable or active. You need to be thinking, is the pocketing getting worse or better? Actually, you also need to be thinking about the attachment level, because is there attachment loss happening, but it's being masked with a bit of recession as well, but the pocket depth is staying stable. Bleeding on probing in a non-smoker is a sign that things are likely to be active. Suppuration is never a good sign. So marginal bleeding means that there's gingivitis. Bleeding on probing means that there's periodontitis. So recording the difference between the two is really important. And then is it possibly active or is it probably stable? You can never say 100% guarantee, but that's what you're looking at. Is it likely to be stable? Is it possibly progressing? And that's what you want to be thinking about. The BPE is great, because it gives you that quick score when you are carrying out that initial assessment of a patient. So it's a screening tool, and it's important to remember that it is not the in-depth recording that you need for somebody who's got active disease. It is very much a screening tool. It's great, it's quick, easy to do, it's reliable, and having divided the mouth up into sextants was genius, because often the front teeth are different to the back teeth. So it gives you that good, quick map of the mouth, which is great. It's a really helpful screening tool. Disadvantages are hierarchical scoring. It assumes that if you've got 1, it's better than 2. If you've got 2, it's better than 3, and so on, which for most patients is probably true. But you might have some patients who've got some calculus and absolutely no inflammation at all. So a score of 2 would actually, a score of 1 would be worse for a patient like that than a score of 2. Also, for example, a patient that I put on here, a 6mm pocket, there's no recession, it's near the front of the mouth, so it's easy to get to, would score 4, but there might be a 5mm pocket with some recession in a difficult, inaccessible site. So actually, it's a much more difficult situation to deal with, but that would give you a score of 3. Also, the full criteria of when to do a BPA and how to do it are not that well understood by the profession as a whole. And so there are inconsistencies in when it's recorded, how it's recorded. So get good at it. All of the teams together, work together, make sure that you are being really consistent, and really look at the BSP guidelines on when to do it, how to do it. They do change from time to time as well. Do keep up to date with when you need to do a full mouth 6-point pocket chart and all those sorts of things, because the guidelines do change from time to time. Basically, all new patients should have, or all new patients to you should have a BPE. If it's score 0, 1, 2, recorded at least annually. With 3 or 4, more detailed recording needs to be done. And so those are the basic criteria for when you do it. BPEs as well don't give you that ongoing measurement to compare. So for example, a patient might have a 9mm pocket, which you reduce to 6, which is fantastic, but it will still score 4. A patient might have a 5mm pocket, you get it down to 4mm or just under 4mm. Now, again, that's good. It will still score 3. So then you can't do precise comparisons when you're into the 3 and 4 scores. So again, it's important to have more detailed measurements when you've got patients with that. That's an important thing to remember. What is probing pocket depth? Well, yeah, it's the distance from the gingival margin to the tip of the perio probe, moderate probing force. Yeah. So, you know, if you've got a narrow probe, you'll record a deeper pocket. Sharper probes, you'll record a deeper pocket. So again, make sure that you are consistent with the probing that you use. The BPE probes are really good because of the ball end. And they're the same width. So they're quite a universal one that's used in practice. So in your practices, if that's the one you're using, everyone should use the same sort of probe so that you're getting some sort of consistency with it. The harder you press, the deeper the pocket as well. I know that's a statement to the bleeding obvious, but it's important to remember that. So again, there will be differences between operators, between different clinicians in the pocket depths that they measure because of the probing forces. In my experience, people tend to use slightly less pressure than they should, especially when a site is inflamed because the patient finds it uncomfortable. I always used to support underneath the lower jaw with one hand, and I was probing with the other to help with that. Because the probing force should be between 20 and 25 grams. Again, get used to doing that. If they're inflamed, it can be uncomfortable. Also when they're inflamed, you can over probe because it penetrates the base of the pocket. So you know, it's just get good at being consistent with the force that you use. Get good with the angulation of the probe. Again, it's easy to get the angle slightly wrong. Obstructions might cause problems. So if you notice an obstruction, make a note that it was there because it's going to influence the pocket depth that you record. And a pocket is a really complex shape, so you might just miss the deepest part of it. Again, so that might explain why you record it shallower than the next person. Or deeper than the next person. It's just all of these things can have an influence. So loss of attachment. It's basically loss of attachment is the distance from a fixed point on the tooth. People usually go for the cemento-enamel junction to where the probe is. So it takes into consideration recession as well as pocket depth. The problems with measuring loss of attachment, one is if you've got gingival overgrowth, it's really difficult to know where the cemento-enamel junction is, so then you have to pick another point on the tooth. What happens if that changes? What if you pick the tip of a cusp? What if that gets worn down? What if it breaks? What if there's a restoration put in the tooth? The same with the cemento-enamel junction. What if they have a buccal filling placed on the tooth? You know, you've lost your landmark. So clinical attachment level measurements can be difficult to get really consistent over a period of time. So one of the things to do is record the pocket depths and make an assessment of any recession as well. If there is recession there, make an assessment of it, record how you've assessed it, and check whether it is getting worse or not, because it happens from time to time that patients get the recession, the pocketing doesn't seem to be getting worse, but they are losing attachment, and you want to pick those patients up. So that's an important thing to do. Assessing bone levels, important to do, but the only way of doing it is by radiography. In theory, you could do surgery to look for it, but I don't know of any responsible body of opinion that says that that's an appropriate thing to do. Get the basics right as well. You know, is there any bone loss? Is it horizontal? Is it vertical? So make those sorts of notes of the type of bone loss that it is. Again, you know, just think, are radiographs required? If so, which are the best ones to take? Are they being reported on? And most importantly, compare them to the previous radiographs. You want to see what's happening. Is the bone loss getting worse? Is it staying stable? So it's that comparison. Everything in perio is about comparing with before. It's that comparison. It's so important with perio. So always do that. When you see a patient as a new patient for the first time, you don't have that. All you've got is that snapshot of where they are now, so you can advise them about that. But really, what you want to know is that longer term picture. What's happening? Are they getting worse? Are they staying stable? All those sorts of things. And also, you want to put it into context of their age. The amount of bone loss, if you've got 40% bone loss, but you're an 80-year-old, it's okay. If you've got 40% bone loss and you're a 40-year-old, it's not good. If you've got 40% bone loss and you're a 20-year-old, it's a disaster. So again, you need to put it into context of the patient's age. Radiographs tend to underestimate the level of bone loss. Various changes can affect it all as well. So hopefully with modern radiographic equipment in the same practice, some of those things should not be a problem. The angulation can make a big difference. So again, using holders, trying to get things as consistent as possible is really helpful. OPGs, you know, the number of times you see anterior teeth, especially in the lower, where you think, God, those roots are short. And it's not, it's just that they've fallen outside the focal trough. You get a PA and they're normal length roots. So all of those sorts of things can cause you problems. OPGs as well, you've got all of the problems with other bits of distortion, etc. So they're not ideal. If you got them, they're helpful to use, but they wouldn't be the first line of radiograph that you would choose to take. So putting it all together, assess the perio condition of the individual patient, take a complete set of measurements that you decide are needed for that patient, compare with the previous measurements, decide if radiographs are required, and then put it all together. Use your clinical skill to interpret the information. And I think for me, that's one of the most fun things about perio, is that it's not just following an algorithm or something like that. You've got to pull all of these information together and use your knowledge to assess what's happening and make a clinical judgment. And that is great that we still need to do that. I'm hoping that the computer never says yes or no with perio. It will always be the clinicians who make that choice. And then on to which factors can influence success and failure. Well, there are patient factors and there are operator factors. And it's important to be aware of that. Patient factors, interest. do they care whether they got periodontitis or not is really important. Their oral hygiene, of course, is essential. Their systemic health, their smoking, the drugs they take, their immune response, the genetics. So all of those secondary factors influence it. Interest is probably the single most important one. If they are interested in trying to save their teeth, if they buy into the message that it's important to get this under control, they will listen, they will do the oral hygiene, they will try their hardest. Not everyone can physically manage some of the techniques needed to get a significant periodontitis under control. Some patients are just so prone to it. A tiny bit of plaque just causes massive problems, but the more they remove, the more under control it will be. But that interest is the single most important thing. And it's really difficult in general dental practice because you know that patient's not interested and you've still got to continue trying to motivate them. You never know when the light bulb is going to switch on, so never give up. I know it's hard, but really keep that, your motivation to try and motivate up. Operator factors. Our interest, whether we like perio or not, does play an influence on it. Our motivational skills, the way that we can communicate with patients, the way that we can motivate them, does have an influence. The way that we do oral hygiene instruction will have a significant influence. There's the debridement technique, the way that you can actually clean things efficiently, effectively, is important. So get really good at it. And then there's the X factor, and that is just, do you gel with that patient? And you know, it's does your style suit the patient? Does the patient's style suit you? And that is impossible to define, but it does have an influence. And then when it comes to managing patients' expectations, I think it's something that we as a profession haven't really fully got to grips with yet, but patients carry out a lot of their own research, and there's that strange thing that if you read something, you believe it's true. And so patients doing research can have a profound influence on what they believe. And for us to dig into that takes time. As you get to know your patients, you start to understand those things, but it can be really difficult. And, you know, here's some quotes. This was from a practice website. You know, teeth in a day are the gold standard in full mouth dental reconstruction. Well, I don't know what responsible body of opinion they're quoting. I personally would disagree that it is the gold standard. It is one of the treatment methods that can be used. But if a patient believes that and you don't know it and you're not offering that, you know, how are you going to meet their expectations? And then the next two are from the Journal of Clinical Periodontology. And again, patients now have more access to things which used to be limited to the profession only. So they might read things and have information, but they don't have the knowledge to interpret the information. So, you know, the scientific evidence of the possible associations and implications of perio care and the prevention of patients with cardiovascular risk. We're understanding more about that. But if a patient thinks, I'm going to get my gums under control to stop myself having a heart attack, and they have the heart attack, their expectations aren't going to have been met. So, you know, it's good to get the gum disease under control. It might help prevent some cardiovascular problems, but there's not that simple direct relationship. So you know, understanding whether that's an issue for the patient or not is really helpful. Now, I know it's a quick, simple, easy message of, you know, floss or die, but, you know, it's not necessarily true. And then, of course, you know, the next one, you know, I am not qualified to deal with that. I'm not qualified to deal with the expectations of a patient, you know, that maybe getting their gum disease under control is going to help other parts of their romantic life. Really, I wish I'd never read that. I know again, there's a nice, simple, easy line of floss or flop, but you don't want to be using that for patients. So, it is that careful research, evidence-based conclusions is really important, that you know and understand how these things influence each other. You don't overstress things, you don't understress things, and that's really important. And then, what do I expect for successful periodontal treatment? Well, I expect a patient to be like that, engaged. I expect a patient to be responsive. I expect a patient to become obsessive compulsive about cleaning. You can't see her teeth. So from my point of view, if she looked a bit like a horse when she opened her mouth, I would be happy, so long as the gums were healthy. But again, it's important for me to understand what is driving the patient. I had one patient once who it was fantastic. When they first came to see me, all they wanted to do was try and save their teeth. They worked really hard. They got the perio under control. It took a few years, really, really good. And then they turned around and said, actually, I'd like to improve the appearance now. So that's fantastic. Their expectations have changed. And because they've got the disease under control, can do something about it. Had to be really careful to warn them, look, there are limitations in what can be done. By changing some things, it might impact the perio, all those sorts of things, but it's great. That's somebody who is well motivated. It's somebody who wants to do things, which is fantastic. I know as a specialist it's easy because the patients who are referred to me will only stay with me if they buy into the message. And it is much harder in general dental practice because you've got to carry on trying to motivate them. But it's important that from the start, you explain what you can do, the limitations of what you can do, how much the patient will need to do to manage expectations. And I love this quote. The biggest problem with communication is the illusion it occurred. We all think we're good communicators. We could all do better. We, in consultations, give patients a huge amount of information. Do they actually take it on board? They might make all the right noises, they might make all the right gestures, but do they remember what's been said? And again, one of the beauties of perio is that you see patients over a long period of time, so you can be reinforcing, which can really help. But it's always that check. Has the patient truly understood? And there are loads of different techniques for doing that. So, it's just a case of, doing your best with that. And just to let you know, there is an e-learning course on our website. It's been developed with the BSP. It gives you 3 hours of verifiable CPD. So if you're interested in this, you can find out more. You can go onto our website, you can use the QR code, and you can do that course. It's in modules, so you can stop and start it, and it just gives a lot more information, a lot more of the background about this. And that's basically it. I hope you found that helpful. We've got some time to do some of the questions. There's one here. How do you manage a new patient that's been informed they have gum disease when their former dentist did not diagnose it? That's a biggie, and that's quite a common one. So thank you for asking that question. Sometimes patients misreport things. Sometimes they haven't understood what's been told to them, so they might have been told it. You don't know. It's a really tricky situation to deal with, but the best thing to do is to say, look, this is what I found. This is what I think needs to happen. This is the treatment that I advise. And if they ask questions about what their previous dentist said or did, you just say, I don't know. If you've got any concerns about what they've said or did, put your concerns to them. And then make a note in your records that that's what you advise the patient. Because unfortunately, sometimes patients will misreport what you say and tell the previous colleague that you said things about how bad they were, etc., which isn't what you've necessarily said. And it's horrible to get criticism like that, especially when it's not what you said. So it's just that this is what I've seen, this is what I think we need to do. And then if they persist, if they've got concerns, put those to the colleague. So that's one. Another one. How do I manage a boss who is doing Invisalign on a perio patient and does not send for hygiene during the duration, sometimes up to 2 years? Oh, that's an interesting one as well. How much time have I got? Yes, I will hopefully get this answered. The patient, it is up to the treating clinician to ensure that they are acting appropriately, that they are monitoring a patient, that they're diagnosing and that they're treating. If you've got concerns about that, talk it through with them. Explain to them why you think it's important that the patients are diagnosed, treated, sent to you, if it is you or them doing the treatment themselves. Discuss it. If you've still got concerns after those sorts of discussions, get in touch with us, get in touch with your defense organization, and we can discuss how to handle that situation. It's always ideal if in a practice there is clear, consistent communication throughout the team, because there are some patients who are looking for different people saying different things and saying, oh, none of them know what they're talking about. And again, that can easily happen in a situation like this. So it's ideal if everyone, you don't have to be saying exactly the same thing, but you're all going in the same direction. So that's really important. Another one, if another clinician in the last 3 months has already done a BPE, do we need to repeat it again, especially if it's the first time we are seeing the patient? That will depend whether you've got those records or not. If they're coming to you new in your practice, then I think you should do the BPE so that you've got your baseline chart. If you've already got those BPEs from your practice and you're just a new clinician who's seeing the patient, then you don't necessarily have to, depending on what the scores were. So it's that new patient to the practice, I think, is the dividing line. And then another one, have there been cases of litigation against hygienists who a lot are working solo in 30 minutes appointment? They won't always have time to be carrying out 6-point pocket chart. Slightly complex answer I'm going to have to give. If the patient has been referred to you by a dentist, the dentist is responsible for the overall care of the patient. And they should tell you in the referral what they're expecting you to do. Ideally, again, is that working well as a team. If the dentist refers for you just to do oral hygiene instruction or just to do debridement, that's what they're asking you to do. If you think the patient needs more, you should discuss it with the dentist. You should discuss why you think a patient needs more. And again, if you see a patient who you think needs more, I would advise that you make a note of that. You discuss it with the patient, make a note of it, explain why you think they need more. Always have to handle those situations with sensitivity and with tact. But if you are seeing a patient under direct access, then the burden of responsibility lies with you to diagnose and treatment plan. So then you are much more likely to be litigated against. And I think I've got time for one more question at least. So, in terms of duty of care, if I see someone for an emergency appointment, and then they have an unrelated issue, does it still apply? No, is the short answer to that. If you are seeing someone for urgent care for an emergency, it is perfectly acceptable to just deal with that emergency issue, with that urgent care. So you are focusing on the single issue that they have got. If the urgent care is as a result of perio disease, then obviously you need to tell the patient that they got perio disease, and you need to tell them that they need more care, more treatment after you've tried to resolve the urgent issue. But quite frankly, if you are seeing them because they've got a broken tooth, it is absolutely fine to just focus on the broken tooth, deal with the urgent issue, and then say to them they should come back for a full examination. And that's absolutely fine. And let's see if I can just answer one more in the last minute. Should erupted wisdom teeth still be included in a 6-point pocket chart? I'd say yes. Yeah, if they're through in the mouth, do them. Not least because it can be affecting what's happening on the 7, or if the 7's there, can be affecting the tooth that's in front. So if it's fully erupted, I would do it. The BPE criteria are that you don't need to do the wisdom teeth, but if it's an erupted wisdom tooth, I'd include it in a 6-point pocket chart. And I think that's it. So thank you for attending. I hope it's been helpful. I hope it's been enjoyable. And I look forward to seeing the feedback from the survey.